take a graph and show decade by decade how the T levels are dropping, and you superimpose it with a graph on diabetes, obesity, metabolic syndrome in our country decade by decade, it mimics it. I mean, it just goes right the same way. Obesity is rising, diabetes is rising. And I think these are all things.
What's up, guys? Dr. Alex Tatem here. And today I am joined by my friend, mentor, and colleague, Dr. Mohit Khera. We are currently here at the Sexual Medicine Society meeting of North America. And I can't tell you how pleased I am to sit down with my colleague and talk about, our passion for, testosterone and men's health. Dr. Khera, how are you?
Great to be here. Thank you.
So, Dr. Khera, we first met whenever I was going through fellowship with Dr. Lipschultz at Baylor back in 2018, which was a journey that you made, pretty similarly a number of years before that. 10 years before. That's right. It's funny to look at the year and realize, how time has moved on, since then. But something that I think that I've observed even in my career, and you've absolutely observed, is kind of the explosion in popularity of testosterone therapy and a surge in academic interest regarding its safety, how effective it is, what are the risks, what are the benefits. And something that I wanted to ask you about is, could you give us a little bit of insight into the idea that testosterone levels have been dropping as time's gone on?
Yeah, there's no question. If you look decade by decade, testosterone levels continue to drop. Now, there's many reasons for this, but we do know that testosterone levels don't drop simply by age alone. It's a slight decline. When I used to start giving these talks, I used to talk about andropause. I'd say as men get older, the levels go down as they get older, but it's not age, it's the acquisition of comorbid conditions as we age. For example, obesity, diabetes, metabolic syndrome, sleep apnea. That's what drops the T, not just simply age alone. A healthy 80-year-old man still should be relatively in the low normal range if he's completely healthy, right? So if you take a graph and show decade by decade how the T levels are dropping, and you superimpose it with a graph on diabetes, obesity, metabolic syndrome in our country decade by decade, it mimics it. I mean, it just goes right the same way. Obesity is rising, diabetes is rising, and I think these are all things. Other things that cause a decline is stress, right? So it's becoming a much more stressful environment. Sleep, you decrease your sleep, you decrease your testosterone levels, and we're seeing that this is becoming more and more of a problem as men get older as well.
And when it comes to defining low testosterone, obviously, we've got numbers, right? But something that you taught me is that low testosterone isn't just a number, right? And so if you could give us a little bit of insight into the clinical definition of low testosterone, that would be, I think that'd be really helpful for our ears.
It never made sense to me that we had this one number, and they call that number 300. And everyone below that number must feel bad, and everyone above that number must feel good. Doesn't make any sense. Every single man, actually every single woman too, have their own number in which they feel better. Maybe you're 350, maybe I'm 280. All have different numbers. So it never made sense to me. And we know that part of this was done in our lab. Part of it has to do with what we call the sensitivity of the androgen receptor. So for example, Alex, if your androgen receptors, your testosterone receptors are more sensitive, they tend to require less testosterone.
Yes.
If mine are more insensitive, I tend to require more testosterone. And so we're all different. And to have one number for all, it doesn't make sense. So if they're a patient that does have a low normal testosterone level, 350, and he's symptomatic, will I let him try testosterone for 3 months to see if he improves? Of course I will.
Sure.
Right? Because these patients many times will see symptomatic improvement.
And something that I thought was really helpful from kind of a letter of the law standpoint is when we were doing the androgen course earlier in this meeting, Dr. Mohal, who chaired the guidelines committee for low testosterone, clarified and said, well, if you look at the language for that 300 threshold, the language was, 300 nanograms per deciliter is a reasonable cutoff for the diagnosis of low testosterone, but is not necessarily an absolute one, because we know that there are other variables that can contribute. You mentioned androgen receptor sensitivity, which is something that I wish we had open access to as a lab, right? Unfortunately, that's not something that you could test in my office. It's not something that you can test at LabCorp. This is a research program protocol that very few people have access to. But another one is the issue of free testosterone. And so if you could give us a little bit of insight, what is free testosterone and how does that differ from total testosterone, both academically and clinically?
Yeah. So the body really only cares about your free testosterone. It could care less about your total testosterone, but we use total testosterone as a marker for overall sweet.
Yes.
So remember that we calculate free testosterone. There's sex hormone binding globulin, which is made by the liver, and it binds tightly to that testosterone. So the more SHBG you have, the more tightly you bind to the testosterone, and the less free testosterone that we have. So you can imagine if someone has a total testosterone level that's in the low normal range, but they have a very high SHBG, well, their free testosterone is going to be low. And remember, the body only cares about the free T for symptoms. It's the best marker of symptoms. So what we say is if the patient walks in and he has what we call a low normal testosterone, check his free testosterone. Because if his free testosterone is low, that would give you an indication that he's a candidate for therapy.
Yeah. And something else that I wanted to kind of highlight, we talk about levels of testosterone total versus free. And something that I've seen very commonly in clinic is a patient will come in and they'll say, doc, I wanted to get your take on this because I feel terrible, but I got my testosterone checked at my primary care doctor's office and he told me it was totally normal. And I look at the lab and his levels, let's say 280 nanograms per deciliter, but that lab cutoff, their low normal is 275 nanograms per deciliter. So could you give us a little insight into the difference in between what individual labs may be listed versus, what actually is normal?
There's high variability between labs.
Yeah.
A Morgenthau did a study looking at, called up 25 labs, asked them to give them their lowest reference range and their highest reference range numbers. And there was 400% variability, which is significant, which means I could have a normal testosterone in one lab, don't like the lab and don't like the number, go to another lab, get checked, and be low at the same day. So you can change the number depending on sometimes which lab you use. So unfortunately, we don't have a standardized reference ranges between all the different labs. So I think it's very important because how do you then decide if you're a candidate or not for therapy? The Endocrine Society did something very interesting one year. They said, we're no longer going to check, give you a number of 300. What we're going to say is whatever your lab's reference range is going to be the range. So if your lab's reference range says 250 to 800, then 250 is the number. If your lab's reference range says 280 to 700, that's the reference. But you just understand the problem with that is that if their lab reference range says 180 to 900 and I'm 190, I'm normal, but that's not normal.
Not even close.
Right. So that's a problem.
Yeah.
Right. That's a big problem.
Yeah.
And so I tell, we talk to the residents, I say, look, don't get so fixated on the number. Just listen to him. Talk to me about the symptoms. What is he experiencing? But the symptoms to me trump the number.
Yeah. And that's something that I very much appreciated during my training at Baylor is, really the focus and the emphasis on the patient and not on the number. But I think that gets back to kind of our ethos in men's health and sexual medicine. Really, like we are focused on quality of life. We're focused on the person in front of us. We're not necessarily focused on, some esoteric metric that, can go up or down. We want to make sure that we're meeting our patients' expectations.
Yes, I agree.
And something that I think that we should highlight is that, yes, we are trying to make our patients feel better when it comes to offering them therapy for their low testosterone. But there's some real health risks to not treating low testosterone. I wondered if you could give us some insight into that.
That's really important. So I want you to think about this in two different ways. Everyone knows about low T, it causes ED, erectile dysfunction, low libido. Those are the things we typically think about. But I want you to think about 5 other things. Did you know that men with low testosterone level are much more likely to have a heart attack? Non-negotiable. Men with lower testosterone levels are much more likely to have a heart attack. Men with lower testosterone levels are much more likely to have diabetes, obesity, metabolic syndrome. Men with low T are much more likely to have depression. Talk about that. Men with low T are much more likely to break a bone. And there is association with low T and prostate cancer. Association.
Yeah.
So you show me another blood test, any blood test that correlates better with a man's overall health.
Yep.
It's not his TSH.
Yep.
It's not his hemoglobin A1C. It's his testosterone level.
Yes.
At T level, with one T level, I can tell you your current health status and your future health status
Yep.
with a simple testosterone blood test. And I would argue that every man over the age of 40 should get that testosterone level checked annually. I walk into my internist office, and every year he checks my thyroid, the TSH, the screen. I said, why are you checking my TSH? He said, well, that's what we do. We just check a TSH every year. I said, the yield is 6% at best on a man. I said, check my testosterone.
Yeah.
It's a much better screener for my overall health.
It's much more prevalent in our society than hypothyroidism.
Yes.
Yeah. And I think that this, kind of gets back to a theme that we've seen in our specialty, that whether it's testosterone or, it's, let's say, sperm counts and the infertile population, really, our testicles are kind of the canary in the coal mine when it comes to overall health.
Yeah.
And when we start to see, pathology there, it could be a sign that there's something else going on. And now's an opportunity to intervene to significantly improve prognosis lifelong.
Yeah. There are 3 canaries in the coal mine. The first one is a low T level. It's a canary in the coal mine about the conditions I just told you. The second canary in the coal mine is a semen analysis. With a semen analysis, studies have shown you can predict who has a testis cancer today, higher risk, who's more likely to get prostate cancer in the future, so cancer is real, who's more likely to get obesity, metabolic syndrome, diabetes, so many numerous conditions. And remember, healthier people are more fertile. That's the way it is. So if a man has low semen parameters, it's a marker of poor health, right? It's a marker of poor health. And the last canary of the coal mine is ED. You know this. We talked about a man with ED is much more likely to have cardiovascular disease, increased risk for MI, right? Even stroke, right? So with a semen analysis, a T level, and assessing for ED status, those are 3 huge canary of coal mines in men.
And what you just described is our bread and butter in men's health.
Yeah.
And so, in a sense, we're almost the gatekeepers for so many men who don't see their primary care doctors, but they have a problem in one of those areas. They're fatigued. They've had difficulty with weight gain. They can't put on muscle. Maybe they have some erectile dysfunction. Maybe they've been trying to get pregnant for a year or more and it hasn't worked. Those are things that you and I see in our clinic every single day. And absolutely, we have a chance to intervene and we have a chance to improve that specific issue. We also have an opportunity to say, hey, this is a sign that there's something else going on. And I want to see you thrive. So let's talk about some lifestyle changes we can make.
Yeah.
So, we're in a much better place 10, 15 years from now.
It goes even deeper than that. I love that you're going to this because think about this. I remember when I was 30 years old, there was no way I was going to go in and get an annual physical.
Yeah.
There's no way. If someone says, go in and get your blood pressure checked every year, get my hemoglobin A1C checked, there was no way. And most young men are not going to go in and do it. But did you know that if you look at men who present with ED, erectile dysfunction, they're at my door first thing tomorrow morning.
Absolutely.
First thing tomorrow morning, right? Do you understand that first thing? And we know that those men, young centers, at University of St. Louis, 30% of them have undiagnosed diabetes or prediabetes. That's a big number.
Yes.
So I say, look, they could also have occult cardiovascular disease. And don't forget that ED is strongly correlated with mental health, depression, and anxiety, right? So now we got some real conditions that could be associated with this.
Yeah.
So the biggest mistake we could do is hand him a Viagra and say goodbye.
Yeah.
That's a problem, right? Because what happens is you let the diabetes and the hypertension and all those conditions fester for 10 years or so. When it finally becomes symptomatic, he comes back and now he's got to be on the statin or he's got to be on metformin. You could have intervened 10 years earlier when he showed up.
Yeah.
So the biggest mistake, it's a disservice to hand the man Viagra and say goodbye. And I firmly believe that we have this unique opportunity. ED is the gateway to changing their behavior for their overall health. They will listen to me about ED. If I say, look, you got to improve your diet, exercise, sleep, and stress, and you're going to have an improvement in your blood pressure.
Yeah.
Good luck.
Well, I mean, it goes back to what we talked about earlier, because, obviously when you're a patient and you see a number that's high, you see, a 130 LDL, what does that mean? That means nothing to me. That doesn't have any effect on me. I don't have any frame of reference for that. But if you're telling me I can't perform in the bedroom, well, that's a real problem. That is a huge change from my expectations.
Right.
And so when you couple that with, hey, this is a significant issue. This shows us that your health trajectory is not going the way that you want. I mean, that's when you listen, because it has an immediate effect on your life and it hits a lot harder.
Right. But when you tell that same patient, hey, you know what? I want you to start lifestyle modification to improve your sexual function. And using lifestyle modification will significantly improve your sexual function. You can talk about studies we should 160 minutes a week of cardio exercise, been 6 months, significantly improves ED. We know getting 7 hours a night of sleep, 7 hours, significantly improves erectile function, sexual function. Certain diets like the Mediterranean diet, antioxidants will significantly improve erectile function and reducing stress. So stress has always been shown. So let's say that person takes it seriously and does the diet, exercise, sleep, and stress reduction program. His sexual function will significantly improve. But guess what? So is diabetes, so is hypertension, so is cholesterol. Everything else is tucked in into those benefits. And you significantly improve their overall health.
So let's say we have this patient that we have diagnosed with low testosterone. We confirmed this on 2 separate morning values. We've had this discussion. What are his options for testosterone replacement? And I think you've got a great mnemonic for this, for I believe the 4 C's. Is that right?
Yeah, that's right. So we look at 4 C's: cost, compliance, convenience, and concentration. It all depends. But I would backtrack and just add another C: children. Do you want kids or not? Right. So if you want kids, we're having a totally different conversation. We'll talk about medications to make you make testosterone. I'm not going to give you testosterone, but we'll talk about medications to make you make testosterone, which is safe and what I should keep your fertility. HCG, Clomid, maybe an aromatase inhibitor if needed. If you are not interested in fertility, then there are numerous other options, and that's where the 4 C's come into play.
So something that has been a defining feature of my practice, something that has allowed me to practice medicine, is easy access to medication through compounding pharmacies. And I wanted to see if you could give us a little bit of an insight into maybe the classic, public perception of compounding pharmacy being like a mom and pop store where they make different, topical creams and salves versus, what we have today with these very high level industrial scale, compounding pharmacies that really make it possible for our patients to get access to medications that they need.
Yeah, great point. So there's 2 types of compounding pharmacies in the United States. There's 503A compounding pharmacies, and those are our traditional compounding pharmacies that you see. There's over 5,000 US compounding pharmacies, 503A. There are 503B compounding pharmacies, and these are called outsourcing facilities. And these facilities have 2 really indications. One is if there's a shortage of a drug, they're allowed to produce that. And the second is both 503A and 503B have what we call bulks list, what they're allowed to produce. And the FDA dictates what's safe when they're allowed to produce or manufacture. As of this year, they stopped using categories. So these used to be category 1, category 2, category 3. It was on category 1, you could produce it. Category 2 means it's potentially unsafe and it's not legal for a compounding pharmacy to produce that product. So whenever you're looking at a product, you have to just make sure that it's hard to really decipher on the 503As, like, is this one better than the other? I do feel comfortable when you have a 503B because the 503Bs are heavily regulated. They have to use good manufacturing practice. They are have strict criteria by the FDA. So it's good to know, is a 503B or a 503A facility? It does help.
And I think it's worth mentioning that, individual patients may not be able to get medication shipped to their house from that 503B entity, but that 503B entity, nine times out of 10, is going to be attached to a 503A, which means that those facilities are both going to get inspected at a very, very high level. And so as a patient, whenever you're starting to look out, I think it's helpful to try and research maybe not just your doctor, right, but also, learn about where your medication is coming from. Because I do think while there can be some hesitancy about compounding pharmacies, maybe due to some, instances from 20, 30 years ago, really well done modern compounding pharmacies offer medication that is on par with anything that you could get from CVS or Walgreens.
I agree. And I think they offer even a greater advantage. It's access and cost. Access and cost on the drug is night and day. It's a difference many times between being able to get the drug and not getting a drug.
Well, so I think something that really deserves some attention, though, is the issue of testosterone therapy and safety. Okay. Because, you lived through this paradigm shift where years ago we thought testosterone caused prostate cancer, and it was verboten in urologic community. Now we've since long proven that is not the case. We've proven that testosterone past a very, very low number actually saturates the prostate. So if you have a testosterone of 350 nanograms per deciliter, or 1,000 nanograms per deciliter, the prostate isn't going to see any more because it's already reached that saturation point. But something that I think we are really keying in on is really the cardiovascular risk of testosterone. And so if you could give us a little bit of context for that historical concern versus where we are today, I think that'd be wonderful.
Yeah, that's really important. I got to put this in the context of the story.
Yeah.
So before 2010, there are numerous studies showing that low testosterone increases your risk for a heart attack. And many studies showing that if you give a patient testosterone back, you may actually decrease the risk of a heart attack. But in 2010 to 2014, 4 studies came out suggesting that if you give a man testosterone, you may increase his risk for a heart attack. At that point, the FDA decided to look into this further. And when they looked carefully, they said, look, we don't see a major signal here, but we want the industry of testosterone to conduct a large randomized placebo-controlled trial to look and see if testosterone actually does cause a heart attack. And that study was called the Traverse trial. And I was fortunate to be involved in that trial. We helped design the trial, monitor that trial. And that is the largest randomized placebo-controlled trial ever published. We had 5,246 patients in our trial. We followed these patients for 33 months. And what we showed was that there was no significant increase in heart attack in those men taking testosterone over placebo. And in order to be in that study, you had to be sick. You had to increase cardiovascular risk, increase risk factors, or you had to have cardiovascular disease. So the concern that testosterone increases the risk for heart attack really is over, with the Traverse trial.
Yeah.
And what's nice about the Traverse trial, we were able to stick in 6 other endpoints with prostate cancer, BPH, depression, diabetes, and we showed that there was no increased risk in prostate cancer, no worsening of lower urinary tract symptoms for BPH, which I think is very important.
That was a historical concern.
Yeah, that was a big deal.
Yeah.
So that was a big deal. So I think the Traverse added tremendous amount of value to our body literature of what we know about the safety and benefits of testosterone.
Yeah. And with the Traverse trial, we saw that there was no increased risk of major adverse cardiovascular events. But I have had some people and some of our colleagues in cardiology point out the risk of blood clots.
Yeah.
So whether in the legs or in the lungs. And I wondered if you could give us a little bit more context for that, especially given the study design and what it was really powered to look at.
Right. So it was only powered to look at VTE as a whole. And VTE as a whole, meaning venous thromboembolism, there was no significant difference. If you break it down into the categories of VTE, like DVT or pulmonary embolism, there was no difference between DVT, between those taking testosterone or placebo, but there was a slight increased risk in pulmonary embolism in those taking testosterone. And the difference was 0.5% versus 0.9%. It was a small, but it was a significant difference between the two groups. There was a follow-up study that came out after that, looking at this data and looking at, we did the study during the pandemic.
Yeah.
It was right during the pandemic.
During COVID, I remember.
And the follow-up study demonstrated that if you take out the patients who had COVID, there was no difference at all.
Yeah.
Right. So maybe the virus itself could have had an impact. We knew it did, because we knew the patients that could have had an impact on those patients getting a PE. So again, I acknowledge that difference. I do see that it's slightly different, but I do think that it's quite small. Like the other factors, that could have affected that number.
Well, I think it's important that people understand that this study was not performed in a vacuum. We went through this major pandemic, and that swallowed our daily lives. And that also affected patients that were undergoing this study, especially when it comes to the risk of venous thromboembolism, which we know is a consequence of COVID-19 infection.
Yeah.
And so I think it's important that our viewers understand that, and that there has been subsequent data that's been published showing that if we remove that confounding factor, there was no difference. And so, as a professional, looking at Traverse, I think that it's given me a lot of confidence to, really speak what I think many of us have been known to be true for a number of years now, that testosterone therapy is both safe and effective. But I think it's worth pointing out that the testosterone therapy that was given in Traverse was topical. And I think that's valuable to acknowledge because there is a difference between topical versus injectable.
Yes.
And I wonder if you could give us a little bit of insight into the PK curves or the concentrations of the drug in a man who's taking a topical versus taking a reasonable dose of TRT with an injection, or how those differ.
Yeah, you bring up a very good point.
Yeah.
Right, because they are different, right? So we know with injectables, there are higher testosterone levels. There are higher rate of erythrocytosis, so a high risk of elevated hematocrits. And there's some data on higher hypertension rates as well.
Yeah.
And hypertension, erythrocytosis can be cardiovascular risk factors, right? So that's important. In the Traverse trial, we did use androgel. It was a gel.
Yep.
And the change was about 140 nanogram per deciliter if you're on the T versus placebo. But those were the trough levels. So the levels were, in a sense, higher than that, but not going to be as high as an injectable.
Yeah.
Right. So you're correct that there could be a difference. There could be a difference with the injectables in terms of the safety profile.
Yeah.
But compared to a gel.
Yeah. Well, I mean, and again, we have plenty of retrospective studies that have shown results similar to Traverse that did include men on injections.
Yes.
But I think that I wanted to bring that up just to give us a little bit of a segue into something that we've seen become much, much more common, or what we see more commonly than we once did, which is, high doses of testosterone, super-physiologic testosterone, which is a different kettle of fish compared to what we see in Traverse. And so I wonder if you could give us a little bit of insight into what are some of the unique risks to super-physiologic testosterone, and how does that differ from the TRT data that we have in the scientific community?
Right, because the TRT data is only placing patients back into the normal range. Right, and so our data on super-physiologic levels is limited.
Yeah.
There are some studies looking at short-term super-physiologic levels with not such significant adverse events, but that's not what these patients are doing.
Yeah.
It's a long-term super-physiologic TRT levels. And so we worry about cardiomyopathy. We worry about significant hypertension, adverse profiles of lipids as well, and significant rates of erythrocytosis. So I am much more concerned about patients who are at super-physiologic levels from a cardiac standpoint.
Yeah. And also, since we are seeing such a explosion in patients on TRT, very commonly through not urologists like yourself and myself, but through different clinics that, again, may or may not have the same level of clinical experience. We're also seeing younger men starting on testosterone who may not be aware of the fertility risks.
That's right, and that's a concern, right?
Yeah.
Because that's essentially what you and I do for a living, is try to bring these patients back.
Yeah.
And bring the fertility back. And unfortunately, many of them that didn't know.
Yeah. Well, I want to respect your time, Dr. Khera. We're coming up on a close. I just want to close out on, this question of what's coming up in the future, because, as of right now, we've seen a radical change in the field of testosterone therapy over the past, 20 years. And now we seem to be at this precipice of this brave new world. We now have peptides in the mix. We have just this explosion in direct-to-consumer marketing. So given what we've seen in the past, can you give us maybe a little bit of a glimpse in the future into what we might see in the next 5 to 10 years in the world of men's health, wellness, testosterone replacement?
Yeah, I'm hoping that in the next 5 years, it's not about giving me a pill or giving me an injection, but it's a really strong focus on lifestyle modification. Everyone comes to me and says, give me the magic pill, give me the magic injection. I said, there's nothing on the planet, nothing more powerful than diet, exercise, sleep, and stress reduction. I don't have a single pill on the planet stronger than those 4. And if you chose to focus on just one of them, just one, has a profound impact on your quality of life. Profound, right? And my hopes is that we keep pushing the lifestyle modification, because not only can it prevent you having a lower T levels, it can reverse T levels.
Yep.
It can truly reverse the condition. And that is much better than the pill or the injection.
Yeah, absolutely. Yeah. Dr. Khera, thank you so much for your time. It's a pleasure as always. And enjoy the rest of the meeting, sir.
Thank you so much.
Take care of you.